can I be more clear about your second question, please?
In some of the more able children with autism Asperger's syndrome, sometimes their difficulties don't show at an early age, and what you might do to find them.
So, actually, let me start by answering your second questions. So, this is a work that we intended to give, to have us have some ratios, some data that policymakers just, require. But on the field, we are overwhelmed by referrals and by work with those children. We are certainly missing a lot of the ones you are referring to as having, high levels and not falsely, worrying their parents or their pediatricians. But you are proud of having done a lot of, awareness work with the pediatricians, so that, for example, when we started ruling this clinic, child psychiatric clinic in 2003, the mean age of children with autism referred to us was 8 years, and now it is like 2.5, and sometimes we receive too much, referrals in comparison with what was the actual state of the children. The phone check, the phone interview was exactly an MChat. The use of the exact items, the 23 questions of the MChat, but one of the reasons why we were just asking ourselves, why did it drop? Why did it change from the first screening? One of the explanations we advanced, but it's just a hypothesis, is that the second phone check was done by the fellow in child and adolescent psychiatry who was just doing this dissertation. So perhaps in the way she was asking the questions, but the questions were, very clear, so yes or no question, and you can have just to read what is written on the paper. Maybe she was giving more cues or more information to parents, or maybe the parents from the first or the second interview changed their mind or just paid more attention to such or such problem. This is something that is not exceptional to us. Many studies that use the MChat do the same way. But talking about cost effectiveness, this may be a little bit, complicated, because it's no more as simple as if you give the questionnaire and then you get the referral. This is a medium step that adds more, complexity to the system, but we have to accept it.
Any other questions? All right, I have a discussion question, you guys. I guess I was trying to think of something that would bring everybody together, and thinking about your different age groups. And then, Molly, we're going to force you to think about the kids, not the moms, for a minute. What would you see, as clinicians, what would you see the minimal assessment that you would need to do ASD? I mean, in your respective clinics, using the data that you have, what would you say is minimal? And then, in a perfect world, what would you like to be able to do to give the parents what you think they need? So a minimal assessment for a diagnosis, and then for families, whatever they need. I thought that would just be something we could. So, do you want to start, Margot?
Okay. I think a minimal assessment is a very good developmental history, and to cover the algorithm items on the disco, not the whole shebang, but and along with that, I think cognitive and speech and language assessments, but also observation in another setting with other children. Sometimes these children are the first child, they have no experience of playing with other children, their parents can't really answer what they're like with other children. So really seeing them in a preschool setting, if at all possible.
So yeah, I'm thinking now of because I do also research with children with Fragile X, and we're interested in the subgroup of kids with Fragile X who also have autism, and it's really hard to assess in these kids, and so minimal. I really feel like they need an ADI and an ADOS.
Because they're hard.
They're really hard, yeah, and it's such a contentious issue whether this is actually real autism in this group. So I feel like a firm clinical diagnosis is essential.
Sì, come avete visto nel nostro studio, noi abbiamo riportato questi dati della CARS, dell'ADOS, della valutazione cognitiva non verbale, e questo perché proprio c'era una grande differenza nell'età in questo campione di bambini, e quindi era anche difficile poter confrontare i livelli linguistici. Sicuramente importante è il livello linguistico sia espressivo che recettivo, oltre a queste valutazioni, e anche forse una valutazione delle competenze adattive attraverso per esempio una Vineland che è uno strumento molto utile, perché poi i bambini ci dà una misura delle difficoltà che i bambini incontrano in vari contesti, mentre l'ADOS è uno strumento che ci fa vedere una difficoltà nell'interazione con un adulto e eventualmente anche con la mamma. Per sapere come il bambino funziona nei vari contesti forse è utile avere anche quest'altro strumento.
In our experience, the minimum would be at least 2 sessions, one with the very good developmental history that we mentioned, and one with a play, interaction with the child, with respect to what is in the ADOS as items. But as we don't have the ADOS in common practice, we try just to share some of the moments with the child, looking for joint attention, things like that. And then it is important for us to have ruled out all the medical confounding problems like hearing, EEG, metabolic and genetic screening, even though some of them do not rule out autism, but we need them. I think it's important. So these both together.
And you have a different population.
Well, first I want to say it's a great difference if you're searching for children with young infantile autism in the age of 2 or 3. That most children that I see in my practice, they are beyond 6 or 7, they already go to school. And there I would say the minimum is the use of a good screening instrument like a social responsiveness scale or the MBAS, that's a German screening instrument for Asperger syndrome and high functioning autism. And I think if those screening instruments prove positive, then a more specialized clinic or practice should be referred to, because for somebody who is not specialized in this region cannot identify children with high functioning autism. So I think the minimum is a good screening instrument.
Well, I just forgot to mention that I was always feeling more comfortable when I was at least one, structured instrument. So we have the MCHA, but in the practice we use the CAS, which is little, less complicated than the ADI and shorter.
It's a lot less. Well, just to sum up what you said, it seems like part of it is there are differences depending on what the reason is and who is coming. So if you are having very bright kids come who are school age, that what you're doing is you're trying to do something different. Or if you're starting with kids who have Fragile X, where you already know something is wrong, so it's no news that something is wrong, but the question is trying to pull out, is this autism or not? That's different than just seeing a group of kids and you're trying to say who has autism. So it is variable, and then it's hard to know how do we get sort of standardized information without overwhelming people with assessments they don't need, but getting enough information for what you do need.
I suppose experience.
Yeah.
Yeah, I think that's an experienced team.
Yeah.
Probably take shortcuts.
Yeah.
Just something you said in your session about this social communication disorder, because my worry there is that people will want the autism language but resources, and so we may think that a child hasn't got any evidence of repetitive or restricted impairment, but just has the social. But I can't see that being a popular diagnosis.
I don't know. I mean, I worry a little bit that it's either people are going to want to use it because they don't want to, with parents of young children and professionals who, you're talking about giving the PDD-NOS diagnoses to young children or clinicians doing that. I think our clinic did that for many years with little kids, and then we realized this is not doing anyone any good. but so using it because you don't want to bring up autism, or other people not wanting it because autism comes with more services. So I don't know. I think that, we have data from now about 8,000 children. That's not just Michigan, but from all over the U.S. that have been collected in various research projects with ADIs and ADOSs and SRSs and, just thousands of data points. And when we looked at that data for kids that had any kind of ASD diagnosis, there were virtually none, a few. I think there were 11 children who had no repetitive behaviors, if you went through all those scales. So that's one reason why the group decided there have to be repetitive behaviors. But I think many people will argue, well, not everyone in clinical practice does this much assessment. And it is true that you can have parents who say, oh, no, he doesn't do anything repetitive. And then if you do an ADOS or you talk to the teacher or you see the child at school, there they are. So if you don't get enough information, then you may not get that. And so some people were saying, look, there are these big groups of PD-NOS kids who don't have any repetitive behavior. I'm skeptical, but we felt like there had to be somewhere for them to go to get some kind of diagnosis. So that's where the social communication disorder came from. But it is going to be new. And mostly people have downplayed that because they've been so focused on, what are the ASD criteria, but I think that is going to be another question. But actually, just one more comment, and then, because, for many years, Dorothy Bishop talked about semantic pragmatic disorder, and then, in fact, when you look at her kids, most of them have ASD, and it's just because people weren't even asking about repetitive behaviors. So you only get what you look for. So I don't know. And I think if you have ideas about it, you should definitely email me and I'll pass it on to APA, because I don't feel like, at least from my perspective, I don't feel like we know what we're doing. We're trying to make sure that they're covered, but trying to represent the real data, and also trying to be sure that I think DSM-4 is as good as it possibly could have been, but it's still at the point where if you take it literally, almost any child in a child psychiatric, say, inpatient unit who's got big troubles would meet criteria, even though no one would say they had ASD. So we're trying to make this more specific, but also not lose the kids that have ASD, including Asperger's syndrome. And we don't want to lose that group or leave them disenfranchised in terms of diagnoses. So I don't know. Sure.
No, if I might still on the same point, in DSM-4, for example, in the disorders that are usually discovered in children, diagnosed in children during childhood, you have some umbrellas.
Yeah.
So, communication disorders and things like that. So social communication disorders would go to which umbrella?
It goes under communication disorder umbrella,
so
not
it leaves
under
completely
ASD.
the ASD area. So this is a risk.
That's true. Your concern is either people who belong there won't be in there because then they can get autism services, or I think that's possible, and then the reverse, that people will put kids in there. If a child is very young and just sees a speech pathologist or an OT or someone who doesn't want to jump into the whole bandwagon of ASD, they may stay there, but that's true already. So, and it does have in big red letters, you have to rule out ASD as opposed to rule out that to get into. I don't know. Anyway, thank you very much for your patience, and thank our group for getting an amazing amount of information across in 5 minutes. So thank you. Let's give them a hand.